Thank you for the opportunity to speak to you today about stroke and COVID-19. My name is Vivek. I'm a neurointensivist, and I oversee the care of complex stroke patients and the system of complex stroke delivery across Northern California, Kaiser Permanente. I have no disclosures. Now, reviewing the literature for this talk, it is pretty clear that while there are lots of publications, there are challenges with developing conclusions from these case series, because most of what's out there are observational case series where it's difficult to assess whether what you're revealing in the paper is an association or true causation or some coincidence, or something you're not measuring perhaps is what you're seeing. And there's a ton of confounding. If you have a study that only looks at the shelter-in-place window, it could be very different than what it looked like for the rest of the year as far as stroke and COVID. And there's tons of papers with very limited geography or very limited demographic observation. And depending on risk factors for stroke or the prevalence of COVID in that community, it can change what perhaps you can draw from that study. And many that I reviewed were not truly fully peer-reviewed in the classic sense due to the time constraints and the nature of a rapidly evolving pandemic. Therefore, it's challenging to draw a lot of conclusions from those. However, as everyone's aware, in March and April of last year, we saw a dramatic decline in STEMI alerts as well as STEMI activations in the ED. And that was mirrored by this stroke data showing that stroke imaging had declined by 39% in this one study. And multiple other trials had shown that stroke activations, stroke admissions during the period of shelter in place had dropped. Here's the Kaiser Permanente Northern California data that we published, showing the 2019 data in blue and the 2020 data in orange. And this is looking at stroke alerts, and you can see a rapid decline in March, and it took until May to go back to steady state. Same thing with admissions. This was matched by multiple observational studies across the globe, even looking at EMS call volumes for MI and stroke. Nobody knows exactly why. Some theories out there as perhaps minor strokes, TIAs, and stroke mimics were not calling 911. Some theories are that people with severe strokes died at home. So this led to additional observations. So here's an observation from Mount Sinai, also published in about April last year, showing that they had 5 patients less than 50 years old presenting with large vessel occlusion strokes in a 2-week period, where they normally would have 0.7 patients. This got a lot of press, in the lay press actually, and led many to question whether large vessel occlusion stroke is more common in people with COVID than the general population would predict. And it's probably true. There's some signal here based on the case reports and small series that I've reviewed. In addition, we also have this larger group of patients that had COVID-19, about 7,000 patients that were reviewed between March and May. And they found that 1.3% of these people had ischemic stroke. And of those, 60% had large vessel occlusions. Now, this is 2 to 3 times higher than you'd expect. I don't know if this is real or if this is another epiphenomenon of the shelter-in-place window, which was March through May, and where the minor strokes, et cetera, were not coming to the emergency room. However, more studies are necessary to draw any conclusions based on large vessel occlusions. That being said, the Neurointerventional Radiology Societies published multiple guidelines and recommendations for how to manage these complex patients. After all, we're delivering care rapidly in the interventional suite, and many of whom have COVID or have PUI status and require special handling, so to speak. And so these recommendations are quite helpful. The question then becomes, well, if stroke is more common, or large vessel stroke is more common, maybe, why would that perhaps be? And nobody knows for sure. However, given the fact that the virus can cross the blood-brain barrier and the alveolar capillary barrier and become hematogenously propagated pretty quickly, the question then becomes, does this start a hypercoagulable state, a prothrombotic state? And clearly, without any debate, people have noticed that there is a prothrombotic state in the study of COVID generally. especially in people who are in the ICU versus people in the outpatient setting. So is that somehow related to a higher propensity to develop stroke? Who knows? There's also hyperinflammatory response in DIC. Could that be somehow related to stroke? Possibly. And then the development of cardiomyopathy that we see in some patients with arrhythmias and CHF. Could that be possibly at play? Possibly. Well, let's zoom out a little bit and let's look at what the literature says about COVID folks who have strokes. COVID patients in general are at higher risk for stroke than influenza patients and higher risk of dying than influenza patients. That is something that's been shown a couple of times. But if you look at stroke in more detail, there were two large observational studies showing that about 1.3% of people with COVID had a stroke. And typically it occurred in the presence of other vascular risk factors. And if you compare the COVID without stroke population to the COVID with stroke population, the COVID with stroke population generally were older, more likely to be African-American, and higher frequency of diabetes, AFib, hypertension, hyperlipidemia, and CHF. They also, interestingly, were higher risk to develop renal, hepatic, and respiratory failure, and higher risk of death and discharge to a destination other than home. So these are sicker patients if they had a stroke with COVID. If you compare the stroke with COVID to the non-COVID stroke patients, there weren't as many differences in risk factors. However, the stroke with COVID patient population had a higher propensity to develop cryptogenic stroke. Let's look at this another way. Let's look at the stroke patients, and we have large databases across the country called the Get With The Guidelines, looking at stroke population. And let's look at the COVID group within this 42,000 stroke population from last year. And the 1,100 patients in this study were found to have COVID. They were more likely, if they had COVID, to be African-American, Hispanic, or Asian in nature. And the stroke plus COVID group had more severe strokes and worse outcomes than the stroke without COVID population. Namely, they had higher NIH stroke scale presentation, higher proportion of large vessel occlusion that we talked about, higher proportion of arrival by EMS, lower odds of discharge with a good outcome, and higher odds of in-hospital mortality. On the treatment side, these folks with COVID plus stroke had similar rates of thrombolytic administration and thrombectomy, which is good news. However, the not so good news is that there were delays in door-to diagnosis and intervention times. So what do we draw from all this? It's hard to draw a lot of conclusions. So these are just some suggestions from my review of the literature. I would say that when managing somebody with COVID-19 and a stroke, we should provide the same level of management as we do to those without COVID. We should optimize the processes for PUI and COVID positive patients to avoid delays. Whether it's in the ambulance rig, pre-hospital setting, ED, we should optimize these processes to safely deliver care. On the inpatient side, we should also ensure that those providing bedside care, including the nurses, therapists, social workers, et cetera, have sufficient education, PPE, and comfort to deliver the care that these folks deserve and optimize their outcomes by doing so. I feel that it's important to surveil this population with stroke admissions for COVID. I think there is perhaps a signal here that those with stroke and COVID have a worse outcomes, and we should therefore prepare the family and or the patient for that possibility. Thank you for your time. It was a large topic to cover in a short period of time. There aren't a lot of recommendations, but I think in the next year, we'll learn a lot more and be able to gather the evidence and come up with strong recommendations. And the AHA, ASA will adopt those, I'm sure. Thank you for your time again.